everybody, and welcome to Includes podcast presented by Proximal Solutions. Before we go into our episode today, there is something that I really need to share with you guys, because if you don't know, you need to know. So if you have not heard about Anchor, guys, it is the easiest way to make a podcast. And I said it is the easiest way because number one, it is free. Yes, it is free. There are also creation tools that are going to allow you to record and edit your podcast right from your phone or your computer. It does not get any easier than that. But wait, there is more. Anchor is also going to distribute your podcast for you so that it can be heard on Spotify, Apple Podcasts, and more. You can even make money from your podcast with no minimum listenership. It is everything really that you need to make a podcast, and it is all in one place. So do me a favor, go in, download the free Anchor app, or go to anchor.fm to get started. Hi everyone, thank you so much for tuning in into another episode of Proximal Includes podcast. I am your host, Marlegny Mourino, and once again, I am so excited to be here with you today, and I am so thankful for you. In the last episode, we took a small dive in the CPT and the changes for 2021. But as promised, for the next episode, or this episode, we're going to take a look at the E&M changes for 2021. Yes, our evaluation and management section of our CPT book. So to recap, the changes to CPT for 2021 included 329 editorial changes, and those changes included or are 206 new codes, 69 revised code descriptors, 54 deleted codes. So 206 plus 69 and 54, that gives you a total of 329. So what is happening with the evaluation and management section for 2021? Well, I've been dying to tell you. I'm so glad that you asked. Let's dive right in. So the E&M office visit modifications include eliminating history and physical exams as elements for code selection, allowing physicians to choose the best patient care by permitting code level selection based on medical decision making or time, and also promoting payer consistency with more detail added to the CPT code descriptors and guidelines. For the AMA press release from September 1st, 2020, so this year, these functional modifications were designed to make E&M office visits coding and documentation simpler and more flexible. This is also going to help with freeing physicians and care teams for clinical irrelevant administrative burdens that led to time wasting, note load, and box checking. Significant changes were made to the E&M codes and guidelines for office and other outpatient, and our code range new and established 99202 through 99215. These changes will replace our 1995 and our 1997 guidelines and will be taking effect when? In 2021. Now, one of the first things that I said was eliminating history and physicals as elements for code selection. I am not saying that these two elements do not need to be documented, and you guys will see what I mean. So once again, I said we're eliminating history and physical for code selection, but I am not saying do not document history and physical. You still need that documentation in there. I wanted to make sure I made that point very, very clear, because there's a lot of information out there, and some is correct and some is not correct. So in 2020, so right now, the appropriate level of E&M service is based on the following components. So we have our history, our exam, and our MDM, or medical decision making, or time. So the time rules we have when counseling and our coordination of care dominates more than 50% of the encounter with the patient and or family, and also only face-to-face time in the office on the date of the encounter. That's currently how we select our E&M codes, right? Good. So what is changing for 2021? As we already know from our last episode, the E&M code selection will be based on one of two elements: time or medical decision making. The amount of documented information in the history and exam sections in the progress note will no longer be considered when selecting the E&M service or the level of service. So we're not going to be, counting all of our bullets for history and exam. Now, I will tell you this, guys, please make a note of this. Medical necessity is still the overarching criterion for code selection. And I said medical necessity twice, and I'm going to say it once again. Medical necessity, that's not changing. That's what we used before, and that's also staying the same. Once again, guys, I am not saying that history and exam do not need to be documented. They still need to be part of the documentation because they're still important components of the progress note. The extent of the history and or the exam is determined by the provider in accordance with the presenting problem and the overall status of the patient. So in other words, a medically appropriate history exam should be still performed and documented. Once again, history exam will no longer be scored for determining the level of the E&M visit, but there's still important parts of the note and may contribute to the time and medical decision making. I'm actually going to say that sentence one more time. History exam will no longer be scored for determining the level of visit, but there's still important parts of the note and will help to contribute to the time and the medical decision making. So those two elements need to be documented. So the criteria for new versus established is going to remain the same. So per CMS, for purpose of billing for E&M services, patients are identified once again as either new or established, depending on previous encounters with the provider. Once again, that stays the same. So what is the definition? If you're not familiar with it, here it is. So for new patient is an individual who did not receive any professional services from the physician or non-physician practitioner or another physician of the same specialty who belongs to the same group practice within the previous 3 years. That's a new patient. Established patient is an individual who received professional services from the physician or MPP or another physician of the same specialty who belongs to the same group practice within the previous 3 years. Okay, so for our new patient codes, we have 99201 through 99205. For established patient codes, we have 99211 through 99215. Okay, so what are the times? The times that we have allotted for each, if you take a look at your CPT book, we have specific timing that it's going to be changing for 2021. So what do we have for 2021 versus 2020? So for 99202, it's typically 20 minutes. That's what we have now for 2020. That's moving to between 15 to 29 minutes. So you see the change there? 99203, our current definition is typically 30 minutes. That is changing to 30 through 44 minutes. 99204, currently, typically 45 minutes. That's changing to between 45 to 59 minutes. 99205, typically 60 minutes. Now the description is going to say 60 to 74 minutes. So that is for new patients. What about for established patients? For established patient, 99212, typically 10 minutes. Now our definition is going to read 10 to 15 minutes. 99213, typically 15 minutes. Now it's going to read 20 to 29 minutes. 99214, our current descriptor or definition is typically 25 minutes. That's going to change to 30 through 39 minutes. And finally, 99215, we have typically 40 minutes that is going to be changing to 40 to 54 minutes. So that's our new time for these codes and part of our definition. So now time, it's now will now be defined as the total time spent by the provider, both face-to-face and also time spent on non-face-to-face activities that are related to the patient's visit performed on the same day of the visit. So what does that mean? That means that it may include reviewing test results in preparation for the visit, obtaining or reviewing histories, time spent on ordering prescriptions, tests, or procedures after the visit, okay? But should not include the time spent on a separately billable services such as an x-ray interpretation. So that's very, very important. So a couple of things to remember. The total time spent must be documented clearly by the provider in order for the E&M level to be determined by the time, and does not include ancillary staff time. Time will no longer need to be dominated by counseling, and all time used for leveling the E&M must be done on the same day of the face-to-face visit. So once again, the time in the code descriptor is going to change from typical to minimum. So the minimum time in the time range must be met. Therefore, if a new patient visit is less than 15 minutes spent with the provider, it may not be billed based on time. And if the established patient visit is less than 10 minutes spent with the provider, once again, that one also will not be billed based on time. So in other words, the total time must fall exactly into the ranges for the code to apply. I'm going to say that one more time. The total time must fall exactly into the ranges for the code to apply. For new patient visits, if the total time is less than 15 minutes, no code will apply. If time is greater than 74 minutes, then we will add the prolonged E&M service. For established patient visits, if the total time is less than 10 minutes, based on time, no code would apply. If time is greater than 55 minutes, then we also do have a prolonged E&M service that we can use. That can only be used, with the level 5 visits. So what does time include? Once again, it includes the time spent face-to-face with the patient, non-face-to-face time. This includes activities that require the clinician's presence. This does not include time in activities that are normally performed by clinical staff like your medical assistants or your nurses. Per the AMA, physicians and other qualified healthcare provider time includes the following activities. So this is something that you might want to make a note of, and that is preparing to see the patient, like review of tests, performing a medically appropriate evaluation and management and or examination, counseling and educating the patient, family, or caregiver, ordering medications, tests, or procedures, referring and communicating with other healthcare professionals when not separately reported. Remember, we talked about earlier about the x-ray, right? The interpretation. Documenting clinical information in the electronic or other health record. Independently interpreting results when not, once again, when not separately reported, and communicating results to the patient, family, or caregiver, and also care coordination when not separately reported, okay? So remember that only the elements that are performed on the date of the encounter may be included in the calculation of time, okay? So a little bit ago, I talked about the prolonged service. So we have a new CPT code, which is 99417. Once again, 99417. I like to say them a couple times because sometimes I read my numbers backwards or opposite or completely off. This code has been created for prolonged services on the date of an office or other outpatient service. Services that take longer than what is outlined on the codes, but this code will be reported. Listen to this, guys. This code will be reported in addition in addition to what codes? 99205 or 99215 when extensive time is spent during the encounter. Okay? 99205, 99215. Okay? So what needs to be documented in the progress note for the codes based on time? Well, I am so glad that you asked. A statement of total time spent and clear documentation of the activities that were performed on the date of service is needed. That's what we need. Statement of total time spent and clear documentation of the activities that were performed on the date of service. Pretty straightforward. So once again, we have our times. Before we had typically this many minutes. Now we have minimum of, and then we have different times for our codes. Okay. So now let's talk a little bit about the MDM. So the MDM criteria for our codes, you'll see 99202, we have straightforward in 2020, also in 2021. 99203, we have a low medical decision making. 99204, we have a moderate medical decision making. 99205, we have a high medical decision making. Then when we go into our established patient codes, we have 99212, straightforward. 99213, low level of medical decision making. 99214, moderate level. And 99215, high level. So let's dig a little deeper into our MDM. So MDM is the other criteria that we can use instead of using time to select the E&M code. So the level will be selected based on 2 of these 3 criteria. The AMA has provided a table with their definition and the instructions in selecting the level, and I will be adding a link in the description of this episode where you can access this particular table from the AMA. Medical decision making includes establishing diagnosis, assessing the status of a condition, and or selecting a management option. Medical decision making in the office and other outpatient service codes set is defined by 3 elements. And those 3 elements are, the first one is the number and complexity of the problems that are addressed during the encounter, 1. 2, the amount and or complexity of data to be reviewed and analyzed. This data include medical records, tests, and other information that must be obtained, ordered, reviewed, and analyzed for the encounter. This includes information obtained from multiple sources or interprofessional communications that are not separately reported. It also includes interpretation of tests that are not separately reported. Ordering a test is included in the category of test results, and the review of the test result is part of the encounter and not a separate encounter. And then this second one, this data, is also divided into 3 categories. So we have tests, documents, orders, or independent historians. We have independent interpretation of tests, discussion of management or test interpretation with external physician or other qualified healthcare professional. And then the third element of our medical decision making is the risk. So the risk of complications, morbidity, and or mortality of patient management decision made at the visit associated with the patient's problems, the diagnostic procedures, the treatment. This includes the possible management options selected and those considered but not selected after shared medical decision making with the patient and or family. So for example, a decision about hospitalization includes consideration of alternative levels of care. Examples may include a psychiatric patient with sufficient degree of support in the outpatient setting, or the decision to not hospitalize a patient with advanced dementia with an acute condition that would greatly warrant inpatient care, but for whom the goal is palliative care. Okay, so 4 types of medical decision making are recognized. That's why we have the straightforward, low, moderate, and high. The concept of Medical decision making does not apply to Code 99211. Medical necessity for the chosen level must be reflected within the progress note. Remember, guys, medical necessity is the overarching criteria for the E&M code selection, and this is according to CMS. And you can find that in the CMS Internet Only Manual. This is the Medicare Claims Processing Manual, Chapter 12. This is medical necessity of a service is the overarching criterion for payment in addition to the individual requirements of the CPT code. It will not be medically necessary or appropriate to bill a higher level of evaluation and management service when a lower level of service is warranted. The amount of documentation should not be the primary influence upon which a specific level of service is billed. Documentation should support the level of service reported. Again, this is straight from the CMS Internet Only Manual. So what does medical necessity does? Medical necessity clearly communicates the complexity of the patient's condition, document clear assessments and plans. When tests are being ordered, documenting the type, that's how you document medical necessity, documenting the type of test and the reason for ordering it. After the test has been completed, documenting the test results, and also continue to document clinically appropriate histories and examinations. So once again, it clearly communicates the complexity of the patient's condition. So what are some tips to prepare for these E&M changes? So the AMA published 10 tips to prepare for practices for these E&M visit changes. Guys, I tell you something, as an educator, training, education, preparation is always key. So, I mean, this right here reminds me, when we made the switch to YCD-10, I mean, in a probably way smaller scale. It's not like changing completely to some of our definitions and our timing and how we're selecting the codes. But these 10 tips that the AMA published are as follows. Number 1, identify a project lead. So to help in the transition and making sure that the staff is getting the education and the internal policies are being written and shared with everybody. Number 2 is schedule a team preparation time. Number 3, update practice protocols. Number 4, consider coding support. Number 5, be aware of medical malpractice liability. Number 6, guard against fraud and abuse law infractions. Number 7, update your compliance plan. Yes, compliance plan. Make sure that these are updated. Number 8, check with your electronic health record or your EHR vendor. Number 9, assess financial impact. And number 10, understand additional employer or payer or medical liability coverage requirements. So I'm also going to have the link for these tips in the description of the episode. Wow. So guys, we covered so much in our episode, and this was just a super quick overview of these changes. But as always, you can reach out to me if you have any questions or if you need me to elaborate a little bit more on these. But in the meantime, guys, I will catch you on our next episode. Have a great day.